Subscribe to our YouTube channel and don't forget to press the bell icon to get all the latest updates. As India and the world grapple with the coronavirus challenge, on the program today we're joined by a critically important voice in this global conversation. Dr. Soumya Swaminathan is the Chief Scientist of the World Health Organization. She joins us today from Geneva. Welcome to the program, Soumya. I think I want to start by asking you what everybody wants to know, especially here in India. Is there anything to feel just a teeny weeny bit better about? Is there any forward movement? Is there anything that kind of gives the world hope and breathing space at this point?
Yes, I understand why you're asking me this question, Barkha, because there's so much anxiety all around about this new virus and this new disease. And, you know, it's hard to believe that it's been less than 3 months we've known about this virus. And I think let me tell you all the positive things and why we can be a little bit optimistic. Firstly, I think we learned about this virus so quickly compared to some of the previous pandemics or big outbreaks that we've had. You know, we had sequences of this virus within a few days of China actually declaring that they had this new cluster of unusual cases of pneumonia. Starting from there, we were not only able to develop diagnostics very rapidly, but the world was also able to start moving towards developing a vaccine. And so we have today, 50, 60 vaccine candidates that are in early stages of development. 1 or 2 have gone into clinical testing and phase 1 trials. We have had a huge sort of global focus on developing diagnostics of different kinds, starting with the molecular diagnostics that you need to diagnose infection in a patient, to blood tests, which can be used as rapid diagnostic tests, to platform technologies that can run large numbers of samples, to serological testing, which looks for antibodies, which is useful more for research and surveillance. So that's the second thing, is a huge amount of science that has happened, and with practical applications in the last 10 to 12 weeks. The third point for optimism is that where countries have put in place certain well-established public health measures, these have worked. There's no better example than China. For the last few days, they've hardly had any cases arising from within China, and the new cases that they're reporting are all people coming from outside the country. We've seen a reduction, a flattening, and a downward turn of the curve in South Korea, in Japan, Hong Kong and Singapore had it well controlled. There's been a little bit of resurgence over there. What we are seeing repeatedly is that when countries put in place measures that can stop transmission, then it works. So that is, I think, an important and positive message to take away. And as we look forward, we are going to see advances in treatment, evaluating drugs that are effective for treatment, for prevention, in vaccines. There's a huge amount of also, I think, global solidarity, collaboration about sharing data, sharing information. The number of journals that have gone to completely open access, there's nothing related to COVID just behind a paywall anymore. Because if any journal does that, they are immediately shamed by the global community. So everything is now open access, which was running several large data platforms. So it's brought out also the best in people.
But let me ask you, since you're talking about treatment, Indian Council for Medical Research has actually cleared and even recommended the use of hydroxychloroquine for high-risk people who may be at great risk of exposure, including health workers and household contacts of those with confirmed COVID cases, Dr. Swaminathan. Now, the World Health Organization has not yet, as far as I know, please correct me if I'm wrong, taken a categorical position on the use of chloroquine, or what in India at one point we used to know as quinine. Where does the WHO come in on this particular drug?
That's a very important question, Barkha. And it's not only about chloroquine or hydroxychloroquine, but there are a number of other drugs that are in the pipeline or that have been considered as potentially being effective against coronavirus, against this COVID-19. Obviously, I think WHO's topmost priority is to establish the evidence for the efficacy of any one of these potential treatments, because we want to save lives and we want to prevent people from getting the infection, healthcare workers and other high-risk groups, as you just mentioned. The problem is that today there is a lack of evidence on which we can make recommendations. There have been a lot of lab data generated, a lot of in vitro data showing that this drug and that drug would have potential efficacy against the virus. Now, that's a long way away from demonstrating that when you actually give it to people in the doses which can be tolerated by people, that it has an impact on any of the clinical outcomes. So we're not just interested in whether it kills the virus or reduces the viral load. We're also interested, more importantly, in knowing whether it reduces mortality, whether it reduces hospitalization and the need for intensive care. Can it reduce the severity of illness? And if it's taken prophylactically, as has been suggested for chloroquine, does it reduce the risk of getting infected? Now, these questions can only be answered through well-designed research studies. And so what the WHO is saying is the need of the hour today is to generate this evidence. And to do that, we brought together the world's leading scientists in February of this year. So within a few weeks of the outbreak starting, we had a big research and innovation forum where we outlined what the key research questions are and the knowledge gaps are to encourage researchers around the world to answer those questions in a collaborative manner or within each country, but do it in a well structured way. And so based on that, we're developing several protocols that we call solidarity protocols. And we are inviting countries to participate in these research studies. The first one to be launched this week is the protocol where we're testing 4 different drugs for effectiveness and safety in treating COVID-19 patients of different severities, with different comorbidities, of different age groups. And what we're hoping is that in a couple of months, if many countries join, many hospitals join, we will have thousands of patients enrolled into this randomized clinical trial that will give us a definitive answer on whether any of these drugs, including chloroquine, including lopinavir, ritonavir, which is an anti-HIV drug that's also been proposed to be effective, remdesivir, which is an experimental drug, are they really effective? And what do? Do they reduce death? Do they reduce severity? When can they be used? What are the side effect profiles and so on? The other trials that are following very quickly is going to be the one for using chloroquine, healthcare worker and other high-risk group prevention to be used as a preventive. And then we have a couple more in the pipeline. So my suggestion to any country or any organization that is wanting to protect people, obviously I think that's high priority for national governments, is to do it in a framework of research, in a framework where you can collect the data and that it makes sense, it can be analyzed, and then it can inform further guidelines. Otherwise, we might be in a situation where there's a shortage of all of these drugs. People are panic buying, and I can tell you that there have already been reports of 2 cases of chloroquine poisoning from Nigeria because there's this rush to buy chloroquine and start having chloroquine, to protect themselves. So there needs to be a very measured and evidence-based, I think, response. And if we can generate that data, that it can help to guide policy and practice in India, but also in other countries.
Now, obviously, you're making a really good argument, speaking as a scientist. But what's happening to doctors, ma'am, who have to treat patients is that they're experimenting. They're trying all kinds of things. They're trying all kinds of combinations. And there's that sense that one doesn't have time. There's a panic in India and all over the world. Where do you officially come in on this kind of experimental use of, let's say, hydroxychloroquine or the HIV sort of drugs, or the azithromycin that is being used in combination with the chloroquine? We did read two reports, one from France, one from China, saying the lab results were positive, but I think the French report was just on 36 people. I think the sample size was just too small. But in the absence of time for a proper trial and to await those results, what should doctors be doing according to the WHO?
I can understand the position of doctors and other healthcare workers, but what we need to do is what is known to work, which is using the right precautions at the right place when you're handling a particular type of patient, what we call universal precautions. And in this case, if you're a person who's actually testing an individual, like putting in the swab, doing a throat or a nasal swab, you need a certain kind of protection. If you are in an outpatient setting, you need a certain kind of protection. If you are in an intensive care, critical care, where you're doing procedures on infected people, you need a much more, a different level of protection. Those are known to work. Chloroquine may or may not work. I mean, let's hope that it works. But if it doesn't, people should not get a false sense of security that they are now protected because they're taking a medicine. So I think that's the other risk, is that you think you're protected when in fact you may not be. And secondly, we shouldn't leave focus on what is really needed. That's the personal protective equipment that healthcare workers need. And so we need to also tell the public that they shouldn't be using the masks and the other equipment that are needed by the healthcare workers who are in the clinics and in the hospitals treating patients. So I come back to the same message, that we cannot make recommendations or encourage the use of any kind of interventions which do not have the scientific knowledge base. You mentioned 2 studies. Both of these were for treatment of patients, not prevention. And from what I've read of the literature, chloroquine has been tried in many other viral diseases previously because it has some effect in the lab and it has a theoretical basis for an antiviral effect, but it's never been shown to be effective against any other virus. Maybe we get lucky this time and it's effective against COVID-19, but we first need to demonstrate that.
Yeah. I want to ask you about what you mentioned, a very important point about leaving the masks and the protective equipment for the public. Now, wherever you see people, random citizens, when I say random, I mean people who are not health workers or not at the front line of the COVID-19 battle, are wearing masks if they're even stepping out or sometimes even in their homes. Can you clarify once and for all, based on what we know thus far, because even on this there's conflicting report, do you and I, if we're not at the front line of battle, be needing to wear masks? Do we be needing to wear masks and gloves?
I'm in Switzerland now, which has quite a high rate of infection, but I'm not wearing a mask and neither is anybody else on the street. So who needs to wear a mask? Those who have a cough and cold. It could be COVID, it could be just a flu, it could be a cold, but wearing a mask prevents the droplets from flying out and landing, all over the place or flying onto somebody else's face. So certainly the person who has a cold and cough, who's interacting with other people, if you wear a mask, you are protecting those around you. That's the first. Second is those who are caring for people with a confirmed COVID infection. So whether they're in the house or whether they are healthcare workers, because you're going to come into contact closely, and since you're caring for that person, you're going to be close and you might want to protect yourself. And then, of course, are the healthcare workers who are seeing a lot of people, who are sitting in a busy outpatient clinic, who are actually working in a ward with COVID patients. They definitely need, and like I said, there are proper masks which they need to wear. So the ordinary surgical mask, what it does is it prevents when you cough, it prevents the droplets from going out. And so it's effective for stopping that from happening. So if you're not infected and you wear a surgical mask, it does nothing. So again, it's a false sense of security, that you're protected. And moreover, we've seen now worldwide shortages of masks, gloves, goggles, gowns, etc. So we must have some responsibility and protect those for those who are at highest risk, and also for those where wearing it makes sense and it benefits the community.
I'm so glad you said this, because there's so much panic buying of masks and gloves that's taking place here in India, and the laboratories that need it are actually running short. Now, talking about India, Dr. Swaminathan, the WHO motto has been test, test, and test. And the debate ongoing here is that India is simply not testing enough. Initially, the ICMR, I think, did that because they did not want to panic the population. Officially, ICMR has not accepted that there is community transmission, though I think there are many people who are not convinced of that. How do you look at India's record on testing? And we have the usual problem. We have a shortage of the RT-PCR kits. And I'm just wondering what the WHO assessment is of India specifically on testing.
So the WHO puts out guidance on testing. And in fact, today we've updated the lab guidance on testing. And, it depends on where each country is in the evolution of this pandemic. And initially, I think India had a really good approach and put in motion very quickly the testing that was needed for travelers at all entry points, and were able to pick up a number of people who were infected and were able to quarantine them. There was very good contact tracing done and follow-up. But we know the limitation is that this kind of entry screening is not sensitive to pick up everybody. Many people slip through the cracks, and those people are the ones who go in and start spreading the infection in the community. Now, it takes some time for those one or two sporadic cases to infect enough people for it to become visible. So what is needed really is a surveillance mechanism which goes beyond the testing at the points of entry, but also look at what's going on in the community. And this is something that's, again, one of the principles of public health, is to have a strong surveillance system, which India had developed for polio, one of the best, most excellent systems that has withstood the test of time. Not only were we able to control polio, but being able to keep a really wonderful, good eye on it and pick up any kind of vaccine-derived polio viruses which may be circulating. So that's been a real success story and demonstrating that it is possible to do public health surveillance. We have an IDSP network. We have a network of laboratories that are run by the ICMR, the viral diagnostic labs. But every district is also supposed to have now a system to monitor what's going on in terms of infections, in terms of deaths. This is what good public health surveillance. So if you find a cluster of diarrhea somewhere, or a cluster of people who have particular kind of illness, when we have these AES outbreaks, we suddenly see a cluster of children who are getting admitted with encephalitis-like symptoms. So that immediately alerts the local response to go and investigate the outbreak, to find out what it is and to take immediate measures. So that community surveillance, to my knowledge, has not picked up to date any unusual activity, but this is something that we have to keep an eye on. Now, in terms of the testing strategy, certainly, I think when you compare with the global scenario and what other countries have done, India's testing has been limited to those who had this history of travel or history of contact. And I know that very recently it has been expanded now to cover people who have symptoms of severe acute respiratory illness or SARI, in order to make sure that a lot of the pneumonia cases may not be due to this. So I think in the coming days we should get that data. Simultaneously, it would be helpful to know what's going on in terms of real community spread or not. I think one has to establish that, and you can't do it without the data. So what we are recommending is that countries undertake sero-epidemiological studies. So what that means is that we look for antibodies in a subset of the population, and do it in an age-stratified way, and rural, urban, etc. So that you get from that, what you will get is an idea of whether people in the community have been exposed to this virus, because then they develop antibodies.
Can I ask you to clarify? Sorry to interrupt you. I just want you to elaborate on this antibodies testing, because I was talking earlier to people who run major laboratories, microbiologists, and they said that it takes time for the antibody to develop, and therefore we simply do not have that kind of time. And as a layperson, I wasn't able to counter that. So in terms of testing, is it that you would recommend the test kits that India is currently using, or would you say that we need to move to antibodies testing, or is there a third way to test? I know South Korea in particular was able to test very effectively. So what should India be doing, and should we be moving to this antibodies testing instead of what we're doing right now, or in addition to?
That's a very good point. So to be very clear, the testing that India is using currently, and that all other countries are using for the diagnosis, the detection of people who have the infection, is the molecular test, the PCR test, the test that looks for the RNA of the virus. You have to take the sample from the person, and then you have to run the PCR, and obviously that requires some infrastructure in a lab, and that I know now is scaled up, both government and private labs. That finds out if a person has infection now. The antibody test, antibodies take a few days to develop. And there are many kinds of antibodies, but the important ones are IgM and IgG. The IgM develops within a week. The IgG sometimes could take a bit longer, maybe 10 to 14 days. So what you would get from the antibody test would not be helpful to find out if a person is infected or not. What it would do, if you do it in a large number, is to tell you 1%, 3%, 5% of the population has been exposed to the virus and has developed antibodies. And what that tells you is how prevalent is the infection in the community. If you get 0.1%, let's say, you would then decide the measures that you want to put in place based on that, versus if you're having 10% of the people who are already infected. And also this helps you, if you do it at regular intervals, it may also help you to monitor how the outbreak is proceeding in your country. People have talked about herd immunity. People have talked about the population developing an immunity and so on. That's the way to assess it, by doing the antibody tests.
So you would recommend the antibodies test in addition to what we're already doing?
Yes.
How do you explain why some countries have managed to test more effectively? Now, I'm not talking about small countries like Singapore, which obviously, like you look at, a country the size of India and it's apples and oranges. But what can we, for example, learn from South Korea? What can we learn from China in terms of how we should be proceeding?
They decided early on that they were going to go after the virus. They were going to go after each individual. Find the individual, detect, isolate, then track all the contacts and the contacts of contacts, quarantine them, test them, isolate them, go after another round of contacts. Our emergency program head, Dr. Mike Ryan, he often says, from his experience with the Ebola, he's fought many Ebola outbreaks. Unless you go after the virus, you cannot control this. And we could say, this has already gone beyond. But I think the approach that China and South Korea used was to detect each and every individual and isolate them, treat them, of course, but also put all the contacts into quarantine, and did it in different ways. And then keep following up people. They used, mobile phones and things like that to find out, certain areas being at higher risk of spread than other areas. They would use some measures in some areas. So it wasn't a uniform thing across China, for example, or across South Korea. They were very targeted. And they were targeted because they knew where the infection was. So this is why it becomes important to test, because you can start targeting your interventions. You can start focusing down on those areas, at least as long as it's not become completely widespread. Initially it's always starting like that in some pockets and clusters, and you could try to contain it there and not let it go out. That strategy, I think, seems to have succeeded. Of course, it needs to be sustained, and then, now we'll see in China when they start lifting the restrictions gradually, whether the virus actually comes back again or not. That's still an open question.
That was going to be my next question. A very important point from you, that we still need to see whether there is a second wave, so to speak. But in terms of the lockdown, the United Kingdom initially tried a different approach, talking about herd immunity and so on, and then had to retract very hastily from that. In India, we are effectively in a lockdown. Domestic flights have stopped, rail services have stopped, borders of most states are sealed, and so on. There is a contrarian view, however, for example, Adar Poonawala, who heads the Serum Institute here, who's also working on trying to find a vaccine. He said, we have to think of next steps. We don't want bankruptcy and despair killing more people than the virus. Now, I'm just wondering whether the WHO has a position, has an understanding on the efficacy of lockdowns. Are they sustainable? Are they an answer? Can we continue with them, and for how long?
It's an evolving situation, and the issue is that because it's new, it's unprecedented, we've never had anything like this before, we've never done anything like this before, we need to see what is working, what is not working. But we know from the 1918 influenza pandemic, from experiences between different approaches taken at that time, even between two different cities in the United States, which decided to take different approaches. One complete lockdown, and the other was much more liberal. There was a clear difference in the number of influenza cases and deaths in these two cities. So it might be even worth going back and looking at the 1918 pandemic to see what lessons can be learned. Of course, we live in a very different era today. Everything is different. But the basic principles of how the virus spreads in communities is the same. So lockdowns seem to be effective, but it's also very true. What you're saying is that you can't lock down the whole country, the whole world indefinitely. And we need a measured approach, a graded approach. And that's why data is important again, because you can, if you had data, you could use that to direct where you really need to focus all your energies, particularly in huge countries, India, but also other countries like Indonesia, Nigeria, Brazil. All of these countries are in the same situation.
Yeah. What do you do, ma'am, when there is no agreement on data points? And I ask you this because, in India, for example, the Indian Council of Medical Research has one set of officially released data of the number of confirmed patients. And then you have other epidemiologists who are arguing that if drastic measures are not taken, you could be looking at a 300 million infected situation by the end of July. One of the interviews I did actually had the expert argue this. So the data is at two extremes. You have the ICMR data, and then you have projections based on mathematical models that are projecting a very different number. And I'm just wondering how a country makes sense of completely contrarian assertions.
Okay, different things. ICMR data is the actual data on the number of tests performed and the number that are positive. And they have data now from some sentinel surveillance sites on about 1,000 samples, all of which were negative. And they also have data, of course, on all the other travelers and others who were tested, the contacts. Those are actual tested and positive. Now, the modelers, who are the other group of people, and there are several sets of modelers who have produced estimates. Those are estimates. Those are based on certain assumptions. And the models for India are based on assumptions of the spread of infection in other countries. Again, because there isn't a lot of data from India on the community level infection. So models are built on assumptions which you can see that in many countries now, the trajectories are very similar, the way the slope uh, takes off, at a certain point, starting with Italy and Spain and Germany, the US, UK, they're all following the same trajectory. And so if you use that, then you could project a certain way that India could go. But what it doesn't take into account are the interventions. Or some of the models also talk about interventions. If you did this, then the slope would look like this. If you did this, the slope would look like that. So those are all scenario planning and based on what you do or you don't do. But the models would be much stronger if there was more data to feed those models.
Sure.
And of course, for India, such a huge geographic area, you need state level or even district level models, which you can have only when you have that kind of data. So that is why there's this disparity between so few cases actually diagnosed, but the model showing, millions of cases.
One more question. Do we have any science on the temperature, humidity sensitivity of the virus? I keep reading completely conflicting things on this.
I think there is a definite answer. The last week, there have been studies coming out to show that temperature does not seem to have a big impact on the virus. But there are more studies going on in the lab. There are also people watching to see what happens in different climatic conditions. But you see in Singapore, Hong Kong, and in other warmer climates, we've seen the circulation of the virus. But we don't have the final word on temperature, especially very extreme heat, like what you see in North India in the summer. We don't know that, it has an effect on this virus or not. But as of now, we don't have the data to think, well, it's going to go away because of the heat.
Sure. Finally, this is your country. I mean, you're in Geneva, I'm in Delhi, but this is your home country. What would you be advising us to do at this point? Should we be building ventilators on a war footing, as some have argued? Should stadiums be ready as temporary shelters? What should we be doing next? We're effectively in a national lockdown. What next?
You have to do many different things at the same time. That's the challenge. We have perhaps a little bit of time still to prepare. You need teams that are working on each of these different aspects. The testing part of it has to be sorted out, and I would think that by opening it up to the private sector, there's some, but it needs to be still under there needs to be a strong governance mechanism. Data needs to come back. India is very good at digital technologies, at the use of mobile phones for all kinds of things, using it for communicating with the public. It could also be harnessed now to do the data gathering and the mapping and the real-time analysis of what's going on. There needs to be a huge amount of public engagement, public cooperation. I think this is one pandemic where you need the public's cooperation. You've seen in lockdowns in other countries, but the public has not taken it seriously. But people have not understood why it is being done, where young people don't take it seriously because they feel they are not at risk. They can even doing their normal thing. It's only the older people who need to worry about it. So there are lots of myths and misconceptions about this disease that people need to be constantly given the right information, credible information, credible people speaking to them. And then you need to prepare for that you're going to have a large number of sick people showing up at hospitals. How do you handle that? If indeed you start seeing a rise of cases, then what's the mechanism? Can we put in telemedicine in a big way to handle, outpatient? Nobody who's not sick should be coming into the hospitals, the next several months. Elective things should be postponed. Healthcare workers need to prioritize. Of course, you can't forget about other things. So that's a very important thing also to think about, that, you have more people dying of tuberculosis. Tomorrow's World TB Day. And India, we have 500,000 people practically, almost 500,000 times of TB. We can't forget about those things. We can't forget about malaria programs, immunization, delivery of medicines for those who have chronic diseases like diabetes and hypertension. All of those programs need to be kept running, while at the same time, you are readying isolation wards. You are readying places where people who are not so sick can be managed. China created these huge facilities where they could manage need health workforce training in a big way. Definitely, the private sector, public sector will have to work together to make this happen. So I think these are the areas where, and I'm sure there is already a lot of planning that's been done, and I know the Ministry of Health has been focused on this issue now for many weeks and months, along with the ICMR and other partners.
Yeah.
But this is a challenge that's, again, like I say, unprecedented. We've never had to face such a thing before, neither India nor any other country. And even the developed world has seen how quickly their health systems have got overwhelmed, and how quickly the hospitals have been overrun with patients beyond the capacity to cope. So that's a scenario to be prepared for, and hope that we won't get there. But let's prepare for that scenario, but take all the measures needed now to see if we can prevent the situation from getting to that.
Thank you, Dr. Soumya Swaminathan. It's been educative talking to you, and it's so important. I keep saying this is not just a pandemic, it's also an infodemic. There's so much nonsense circulating and unverified information. That's why it was so important to hear you. Thank you very much. Thank you very much, and we'll let you get back to work now.